Hey folks, and welcome back to the channel. In this video, I'm going to tell you an incredible story about a very serious catastrophic surgical error and what we can all learn from it. It's an incredible story and one that I think about from time to time and reflect on the lessons for myself, both as a surgeon, but also just about, everyday life. And then I'll tell you about a framework on how to kind of think about all this stuff and what lessons we can all learn so we can mitigate errors and prevent them happening in the first place. So it's January 2000 on a cold, blustery day in beautiful South Wales. There's an operation going on in operating theatre at the operating theatre in the hospital there, like thousands around the country that day. It's an operation to remove a kidney, so it's a nephrectomy, and it is being carried out by a locum registrar who is indirectly supervised by the consultant surgeon sitting in a coffee room next door. Also present is a medical student who is standing in a corner and watching this, again, like thousands around the country that day. However, about a third of the way through the operation, this medical student, her name is Victoria, she notices something not quite right. She notices that the surgeon is spending a lot of time on one particular kidney, whereas she thought it was the other kidney that was the problem. So she raised her concern, having checked and double-checked everything. But the surgeon acknowledged her, he noticed her, he listened to her, but then he didn't really take her very seriously and said, no, you've got it wrong. So this is a newspaper article from about a couple of years later when he was actually going through the courts. So the headline is, "You're taking out the wrong kidney," surgeon was told. And it says here, a surgeon accused of killing a patient by taking out the wrong kidney was warned he was making a mistake by a medical student watching the operation, a court heard yesterday. It goes on to say that Miss Fern, this is the medical student, had looked at the x-rays of the patient's kidney on the wall of the operating theatre and realized that the wrong kidney had been listed for removal. It goes on to say that the court heard that the wrong kidney had been identified on a hospital admittance slip, but the error had been transferred to the operating theatre list even though the consent and the notes had the correct information. So it wasn't just a case of one error at the end. It was a cascade of errors which had sort of culminated in this catastrophic error. Now, unfortunately, and very sadly, the patients ended up dying about 6 weeks later. Here's another article about the same case. Fatal kidney error trial continues. So this is about a couple of years later. And again, it goes through the details and it just says that during the case for the prosecution, the lawyer said the medical student, Victoria, told the surgeon that she thought it was the right kidney which was not functioning and the left one was compensating for it, and the surgeon told her that she had got it wrong. Now, of course, the ultimate responsibility lies with the consultant, who was not present. He was indirectly supervising, but he was the leader of the team, and obviously the operating surgeon as well was involved. And he says here, the ultimate and overriding duty to ensure the correct operation is performed rests with the operating surgeon and the supervising surgeon. And there's a particularly amusing comment here. It says the organ grinder cannot blame the monkey. Their duty is to ensure the correct operation is performed and the buck stops with them. Now, this is a very important case, a very serious case, a very tragic case. The patient ended up dying about 6 weeks later. And I often think about this case because both as a consultant, I have a lot of responsibility, some of which is delegated to other people, but also it's about the system, how the system failed in this case. And this is part of a general rubric of how to think about these things, both in healthcare, in medicine, but also in aviation, called human factors. But just before we talk about human factors, there's a couple of other things which I wanted to point out. There is in the NHS things called never events, and as the name suggests, these are things that must never be allowed to happen. So for example, taking out the wrong kidney, amputating the wrong leg, operating on the wrong patient, leaving something in the patient afterwards. Now, they do a regular audit of these things, and the latest one gives you a little idea of what these things are. So surgery performed on wrong part of the body or the wrong patient, foreign bodies left in patients after procedures, wrong implant or prosthetics, wrong blood transfused to patients. So some of these are immediately life-threatening. Gastric feed tubes placed incorrectly and feed administered, so obviously aspiration pneumonia. So you can see that there's a series of things that must never be allowed to happen, and yet sometimes, despite the best attempts of hard-working, dedicated professionals, sometimes they do happen. Incidentally, all surgical grade gauzes, sterile gauzes that are used in operations, have a black line running down the middle of them. Do you know why that is? The reason for that is because these black lines are a radio opaque strip And so if they get lost in the patient's abdomen or pelvis, you can almost find them using x-rays. So to minimize and mitigate errors and to make the system simpler for individuals to navigate, there are a lot of things that have been put in place. One of them is a team brief and debrief, which is a really good thing to do because surgeons, anesthetists, nurses, everybody gets together at the beginning of the day, at the beginning of every operation, and says what we're going to do, which side and which site, and whether there are any equipment problems and so on. And if there's something wrong, if something goes wrong or there's a problem, it's always a good idea to do a debrief at the end of the day or at the end of the case, so that we can sort of make sure, first of all, that the patient is okay, but also if there are any learning points, if there are any lessons that can be learned to prevent a similar thing happening again. This leads me very nicely to the surgical safety checklist, otherwise known as the WHO. So the first part is sign in, to be read out loud. This is obviously when the nurses check to make sure when the patient arrives in the operating theatre, in the operating room, that the patient is who they say they are, to make sure that the right patient is in the right place at the right time and a catastrophic error is not going to happen. The next bit is time out, again to be read out loud. This is usually done before every operation, and this is basically to make sure everybody knows who everybody is, so all members of the team introduce themselves by name and by role, by designation, and then the surgeon usually verbally confirms the patient's name and the procedure and incision site, again if there's, for example, right or left kidney or what have you. And then the surgeon is asked, do you require any special equipment? So that would be things like an x-ray machine, a microscope, any particular kit that the surgeon requires, and make sure it's there before the patient goes off to sleep. How long will the case take? Now, a lot of anesthetists would smile at this and say surgeons usually underestimate the length of time the operation takes. I usually, as a general rule, tend to overestimate by 10 to 15%. This is so that when you finish on time, people are pleasantly surprised. And then at the end, there's a sign out. Again, it says here to be read out loud. Before the patient leaves the operating room, the nurse verbally confirms the name of the operation. Basically, we did what we planned to do. Were there any issues? Were there any problems? Has the specimen, if there are any pathology specimens, have they been labeled and the form filled in and all of that kind of stuff? This is all adapted from the WHO Surgical Safety Checklist. It's actually inspired by a book by a fantastic surgeon, as it happens, called Atul Gawande, who wrote a book called Checklist, and it's a book that I'll recommend to everyone. Now, this whole idea of error prevention, error mitigation, is generalized under the topic of human factors. And human factors are very important and a very big deal in healthcare. It was inspired by aviation, and particularly after the Kegworth crash. So in 1989, there was a crash of an airplane flying from London to Belfast. It was a almost new aircraft, having been in service for just 2 months. And it says here, a failure on one of the 2 engines led to the engine malfunctioning. In response to this, the crew shut down that engine, or so they thought. So the question is, why would experienced pilots shut down the wrong engine? And unfortunately, the plane crashed just as it was coming to land in another airport, and about 70-80 people unfortunately lost their lives. After it was decided that this was not a technical failure by, a mechanical failure, and unfortunately it was a human factor involved, then they decided to really double down on this and to make sure that this doesn't happen again. In other words, they decided to be good and safe by design, not by luck. And human factors are now mandatory in aviation because about 70% of aviation errors are non-technical. So what does that have to do with us? Human factors is a very big deal in healthcare as well. And there are a lot of wordy and pompous definitions of it, but the one I really like is basically making common sense conscious. I love that definition because it's very simple and it tells you exactly what it is. And it's about how people, individuals, interact with complex systems. In the context of healthcare and surgery, human factors aims to improve patient safety by identifying and mitigating potential sources of error, especially related to things like communication, workflow, and the physical environment. And the mental model that a lot of people use to describe all this stuff is the Swiss cheese model. So it's not usually one individual isolated person doing an individual isolated error. It's usually a cascade of things that unfortunately lead to tragedy. So things like organizational influences, unsafe supervision, preconditions for unsafe acts, and then the problem arises. And if you can sort of intervene at each of these stages further upstream, then you can potentially prevent a catastrophic error. At the heart of human factors thinking is the fact that most people are good. Most people are trying to do their best. Most people are earnest, with very few, very, very rare exceptions. Most people get out of bed to go to work, to do some good, to help other people. But of course, there are a lot of things that influence us as people and our behavior. So a useful framework in human factors is the HALT framework. So if you're hungry, if you're angry, if you're lonely, or if you're tired, it's generally thought to be a good idea not to do anything that could potentially cause an error. Human factors are essentially anything that can impact on our performance. They're obviously a very broad topic, but it's nicely summarized in this table here. And obviously individual factors can be competence. If you think of a surgeon operating, skills, either technical or non-technical, people skills, organizational skills, time management skills. These are all things that can impact our performance. Personality, so surgeons obviously have a very sort of stereotypical reputation for being AAA type, gung-ho type personalities. And that can make some people resistant to criticism, resistance to challenge, attitudes to risk, for example, or risk perception. So all of these are individual factors that can potentially impact on our performance and potentially lead to an error. And therefore, as individual doctors, it's worth paying attention to this stuff in ourselves. The next one is about the job itself that people are asked to do. So we hear a lot about doctors burning out and kind of giving up and retiring early. So what kind of tasks are people performing? What is their workload? What is their working environment? And then the third one is about the organization, the culture of the organization, work patterns, available resources, communications above all, the most important thing. So in the case of this wrong kidney being taken out, if you sort of look at the individual, I don't think there was any kind of question about the competence, but was there an issue about personality? Was there an issue about sort of accepting challenge? Flattening the gradient of hierarchy. Now, in a sort of safety critical situation, you can't entirely flatten the hierarchy. So for example, in the military or in sort of healthcare, in surgery in particular, which is a sort of acute situation, there has to be leadership, there has to be hierarchy, somebody in charge has to tell other people what to do. But generally, if we sort of on a general level flatten the hierarchy so that people aren't afraid to speak up, that will contribute to a good culture at work. If you're getting value out of this video, I'd really appreciate it if you could give it a thumbs up. The button is just down there somewhere. It really helps spread the word, and thank you very much in advance. So what happened in this wrong kidney case? What was the outcome? What became of the surgeons? What became of the medical student? Unfortunately, we know that the poor patient died, and that was a catastrophe. But it's interesting to know what happened afterwards. So after the case, the two surgeons were suspended by the GMC, and this actually became a criminal case. They were charged with manslaughter. It went to trial, which I referred to earlier in this video. And essentially, they were cleared of manslaughter, essentially involuntarily killing someone. And this was after a prosecution pathologist told the court he could not be sure that the blunder had caused the patient's death. So these things are obviously complicated. There are shades of grey. And so the bar for a criminal case, as opposed to a civil case, is obviously much higher. It's beyond a reasonable doubt. And if you can't demonstrate your evidence beyond a reasonable doubt, then you can't convict. So both surgeons were cleared of manslaughter. In other words, they were cleared of a crime, but they were suspended for a period of time. But after serving that sort of suspension, they were reinstated and went back to work. Eventually, however, the surgeon who took out the wrong kidney, not the supervising consultant, but the operating surgeon, eventually was struck off. And that wasn't to do with the wrong kidney case. It was actually to do with dishonesty. And the reason for that was because he had applied to go to America, and on his application, he had replied no to the question, have you ever been suspended? And for that reason, he was actually struck off the medical register. I don't actually know what happened to Victoria Fern. I'm assuming that she's a doctor somewhere out there. If you know her, or if you happen to know what happened, I'd love to hear about it in the comments below. Thank you very much for watching to the very end. I'll see you on the next one.